those of you who know me reasonably well will know that my probably what you know me for is less my particular research outputs, which are okay but not stellar, but more for the contributions I've made over the last 10 years or so to trying to help contribute to the generation of research resources with enough understanding of what the research community's needs are to be able to make those contributions in a meaningful way. So I do still engage with quite a lot of research, but I would say that talking to groups like this is a great treat, because it's an opportunity to have discussions about how to make the resources better and more exciting and more usable for cutting edge researchers. And as Praveen says, my background is as a clinician, first and foremost a neurologist with an interest in stroke, also as an epidemiologist, and involvement over quite a number of years with lots of different types and styles of research and engaging with different resources and approaches, but always with a strong kind of epidemiological fundamental underpinning, including clinical trials, meta-analyses, genetics, large-scale population-based research resources, and always with a kind of big data, large-scale power of bringing resources together, increasing statistical power, etc., as an underpinning principle as well. So that's kind of where I'm coming from and why I've been involved in a number of these kind of large-scale initiatives. So I'm going to tell you a bit about the latest of those, which is the British Heart Foundation Data Science Centre. So the BHF Data Science Centre is part of the fabric of Health Data Research UK. And unlike many of the substantive sites and hubs which operate, at least to some extent, at a kind of some distance from the core of HDR UK, the British Heart Foundation Centre has been embedded within HDR UK from the get-go. So a group of the great and the good put together a proposal for how this might look, and then they held a process and appointed me as the director, and then I started and was given that kind of initial template to start with, and then have been kind of building a modus operandi starting in January of this year. So made some interesting progress in some areas, and I'm just about to share my slides. So hopefully you can now see a slide set. Yep, brilliant. And we'll just start off with the first one. Excellent. Okay, so welcome to the British Heart Foundation Data Science Centre. What's it about? So the vision of this centre is essentially about the kind of cardiovascular, in the very broadest sense of the word, components of Health Data Research UK's mission and vision. So you might encapsulate our vision by saying that we're about trying to improve the cardiovascular health of the nation or of the public using the power of large-scale data and advanced analytics, primarily across the UK, but in the fullness of time through creating international partnerships to realise the larger scale vision that comes with connectivity internationally. And obviously some of those international connections already exist, not least within this forum that I'm engaging with right now. So many of you, because you're engaged with Health Data Research UK in general, will have seen this slide, which was created by the HDR UK central team, and sort of encapsulates the current visible view of how HDR UK is going about its core business. And there are three major components there. One is about bringing data sets together. And in my world, the key interest here, or in my view, the key interest here is in bringing together data sets that have national or at least very large scale coverage in terms of population and geography, but also depth and complexity where it's possible to achieve those as well. And as many of you know, Health Data Research UK's key sort of way of achieving that is through the alliance working with the many and varied data custodians that exist across the complex environment we have in the UK, and the HJUK Gateway tool, which is really currently a tool mainly for finding data sets if you didn't already know what you were looking for. And there are many data sets in there. Some of them are duplicated, and it is a tool very much and a process in evolution. But the Gateway has built its functionality, and it's a web accessible tool and environment. It's built its functionality over the months since it started out live quite rapidly, to start to move towards also becoming a means of applying for and in full course completing the journey to access data sets from the many and varied custodians. So I think its aim is to become a one-stop shop. It's also built in some other tools within the Gateway. So the second component of HJUK's business is about improving health data, and the Gateway is also very important there. So it's within the Gateway that links are being created to some of the tools that are for the entire community. And the one that I've probably been most connected with, although with wearing a former, not my current hat, is the Human Phenome or Phenomics Initiative, which is about a resource for people to deposit and then make available for reuse the ways in which they construct computable forms of, or computable representations of, health and disease. And the simplest form of that is agreed lists of codes from various different coding systems to represent health and disease, such as International Classification of Diseases or SNOMED CT or whatever, that specify particular diseases for particular circumstances. And that work is largely being led by Spirasten Access. And then finally, there's the using health data component, which is about taking the uniting and improving elements and putting them into practice in a range of different ways for making research discoveries and implanting those in policy and clinical care forum. So it's kind of, the reason I've gone through that is that really essentially the BHF Data Science Centre is trying to use this framework to operate in a cardiovascular arena. And of course there are the other components around the outside which one cannot ignore, and which are extremely important. So engaging for the purposes of trustworthiness, trust and transparency with public patients and practitioners, users and across the institute, and upholding appropriate values. So if you see the BHF Data Science Centre as the kind of cardiovascular component of that activity, I think that certainly represents my ambition and the ambition of the core centre staff. So we actually want to engage with and look at the ways in which we can facilitate cardiovascular challenges being addressed across all of these 6 national priority areas, which you will probably have come across with respect to Health Data Research UK. So the human phenome, the stuff about computable, reusable phenotypes, applied analytics, which is about advanced analysis methods and their application in a health data science setting, interactions with the Turing, obviously very important there. And then the 4 major components from an HDA UK perspective of how health data are used to better understand causes of disease, in data-enabled, streamlined clinical trial settings, to derive intelligence that helped with improving the public health, and to complete the learning health systems loop so that data derived from health systems can be used to develop tools and plow intelligence and tools back into the clinical coal face through the better care loop, as it's called in HDA UK language. So perhaps understanding the causes of disease will be the area that many of you in Cambridge are most familiar with, as it's the thematic area of activity that is led by John Dinesh. But I would also imagine that many of you are engaged with or interested in all other components of this activity. So in my kind of rather simple clinical epidemiologist's brain, I've kind of divided the world of data into two, and this is, it doesn't work completely, but it's quite useful for me to think of it in this framework anyway. So we're interested, as are many others, but from a sort of cardiovascular perspective, in working with data at scale that are structured, and by that I mean data that are coded or could be represented sort of almost in a spreadsheet format with ones and zeros and dates and codes and so on. And there, my interests primarily are in nationally available data. And there are many data sets available and collated already nationally. The issue has been with accessing them and working with them to make the very best sense of them and understand the issues of missingness and other problems with them, as many of you will know. There are generic data sets which are of great relevance to cardiovascular disease and of great relevance to many other diseases besides, but they are arguably the best place to start for any area of inquiry, not least because any disease or disease domain doesn't exist in a silo. And many individuals who have cardiovascular disease will have either other cardiovascular diseases or other broader cardiometabolic conditions, or indeed a whole range of other conditions besides, through the kind of multi-morbidity and comorbidity pathways that many of you will be trying to kind of work through and understand. So hospital data, very important, already collated nationally. Primary care data now being collated nationally, arguably for the first time really, at least within England, and death registration systems are all clearly critically important for capturing a picture of what's going on at population level for cardiovascular and other purposes. And then for cardiovascular purposes particularly, there are national specialist audits which are also brought together at national scale, either covering the whole of England or England and Wales, or England, Wales and Scotland, or in some cases all four nations, England, Wales, Scotland and Northern Ireland. So it varies somewhat, but these are the main ones that have at least English coverage. So there are several cardiology audits, which there are probably about 6 to 8 of these, which cover various different domains of cardiology specialist and cardiac surgery specialist activity. There are large stroke audit systems, and there are vascular surgery procedural audit and registry systems as well. And all of these, to some extent, cover the same ground as some of the generic hospital data, actually, and some of them draw on the generic hospital data, but they definitely add granularity and detail that is not available within the generic data set. So working at scale with those types of data is definitely important. Also important, but arguably even harder to achieve, is working with data at scale across the UK that are unstructured. So of course, as many of you will know, about an estimate, but probably about 80% of the kind of information about individuals that's collected in clinical practice is not made immediately or ever made into structured form. So it's difficult to derive value from it without additional tooling. And also it's less easy to bring it together and access it at large geographic coverage sort of scale. So that applies, for example, to all the information that's buried in the free text of medical records. It used to be on paper. These days, it's largely in electronic format, which definitely is a good step in the right direction in terms of getting value from it. But it's only ever semi-structured at best, and it does require natural language processing, text mining tools, and an understanding of how those techniques apply within different research settings to really extract value from it. It's an area I'm very interested in. It's not an area I have a massive technical expertise in, but I've been involved in some of the studies that are relevant in this area. There's electronic signaling data as well. Similarly, the value we derive from that is limited at present, partly because the tools that extract value from, for example, electrocardiographs are largely proprietary and quite hard to access. There are tools that have been developed by many academic groups as well, and there are others that will become open source in the fullness of time, I'm sure, but there is, I think, huge untapped value from the potential of these kind of signaling data, whether they're from static electrocardiograms or from prolonged monitoring of these kind of ECG and cardiac rhythm signals, both to understand causes of disease and to improve understanding of the meaning of these signals for immediate applications in clinical care. And then images are another important source of unstructured data. So images of the heart, be they from CT scans or MRI scans or other sources, echocardiography, etc., and images of the brain and images of other components of the circulation. Given that cardiovascular diseases encompass diseases of the heart and circulation very broadly, so it's not just about heart disease, but it's about disturbances of heart rhythm and problems of circulation to the legs and to the head, which might result in stroke, for example, and problems on the venous side of the circulation as well that can lead to deep venous thrombi in the legs and pulmonary emboli and so on. So all of these are kind of encompassed, and the structured, unstructured data division, at least in my simple words, have helped to divide up the task, at least to some extent. So in terms of our progress in the centre, we really kicked off in January when I took up my post, although there'd been a lot of thinking going on before then, and this is clearly part of an ongoing trajectory of the whole research community's contribution in this area. So in a way, we're not doing something fundamentally new, we are building on existing foundations, but we're growing a small core team within Health Data Research UK. We've done a lot of engaging with multiple stakeholders to try and understand what the major requirements are. I haven't heard anything too surprising. A lot of the conversations have been about difficulties with accessing data at scale, you won't be surprised to hear, and trying to rationalize and simplify the environment and means of doing that. We've been establishing some key partnerships. So our major funder is the British Heart Foundation, and actually they're a great partner. They've got fantastic branding, they're well known, charities are kind of respectable and so on, and so that's a really useful kind of cover in a way for a lot of our work, but they also have really good well-developed communications channels and opportunities to engage with their patient and public panels on patient and public engagement activities, which in this world of working with data is particularly important in terms of maintaining the public trust and also the relevance, the public and patients of the work that we do. So working closely with the BHF, it has been critical to us. And for example, I talk to Nilesh Samani, the medical director of the BHF, probably most weeks because this investment is very important for them, and seeing the value of it work for them, it is very important, and they're very keen to support us in everything that we do. So we get bilateral support really, partly from the BHF, partly from HDR UK. To be honest, sometimes the support is a little bit confused and does clash, but is all very well intended. And then another very close partnership over the last few months has been with NHS Digital, where we've been doing some very particular work to try and move forward the agenda in terms of availability of data at scale across the population in England, where there have been some major challenges and where the prize is spectacular of getting it right because of the very large population that is covered if one can do things at population scale in England. So we've been kind of getting bedded down within HDR UK, sorting out our steering group and oversight committee and all of that kind of stuff. And along with many others, doing a lot of work pivoting our activities, well, we kind of hardly started before this pivot began, to support COVID-19 data-enabled research, and also to realise the opportunities that have been created through some of the somewhat more permissive and proportionate approaches to gathering and making data available for research under COVID-19 additional legal powers. So that's been helpful for many people. in some senses, it might have become too much of a distraction, but largely speaking, it's been a kind of important impetus for many of us, I think. And then we've been sort of developing what we're going to do over the next 5 years, using the original proposal for the centre as a template and a starting point. So I think I need to apologise for this picture, because I think it makes most people feel rather dizzy, and it certainly just makes me feel a bit dizzy. So we might replace it with something a little bit less vertiginous in the future, but essentially it's trying to encapsulate the various activities that we're proposing to engage with and facilitate over the coming years. So we have laid out 6 thematic work streams. One is around enabling access to and work with structured coded health data UK population wise, so the structured data segment of this diagram. A second is to realise or look at how we might realise the possibilities of unstructured data in a cardiovascular sense, again at scale across the UK. So I've talked about some of the examples of that. A third is to think about the implications of this for personal monitoring data, wearables and apps, and how to connect those in where they have cardiovascular relevance into this environment. The fourth is to work with HDA UK's phenomics theme or human phenome theme to make best use of existing and contribute new computable cardiovascular phenotypes. The fifth is to work with HDA UK's clinical trials theme and the NHS Digitrials initiative, phenomenon, entity, I'm not quite sure what to call it, on data-enabled cardiovascular trials, perhaps thinking about areas which are not currently being so much championed. So we've been doing some work with the cardiac surgery trials community, for example, who are well organised and have already done quite a lot of work on working out what their priorities are, to see if we can specify and find some good driver projects from that group, but there may well be many others. And then working with the population and, to a lesser extent for the time being, the disease-based cohort community, but population cohorts are quite close to my heart because of my previous job with UK Biobank, but also I've been closely engaging with John Dinesh and others around the multi-omics cohorts consortia, trying to bring together large population-based cohorts to work jointly to realise the possibilities of in-depth characterisation of components of the population through these cohort collections, with their additional omics sample-based analyses, and integrate those together with the world of linked healthcare data to enable a very broad tranche of questions around understanding causes of disease and beyond. So these are the kind of major areas of activity that we envisage being involved in and taking cardiovascular leadership in, but largely around facilitating, enabling and convening the relevant research communities, and then undertaking those activities in the context of coordination and engagement activities, which are really the core business of the core staff of the centre, building the case for these work streams and driving their requirements through specific projects. I'll come on to an example of that in a moment, but really I think it's all very theoretical until you have really great driver projects to kind of bring these areas of activity alive and work out what their needs really are. And then we also have, we'll have a somewhat smaller talent and training program, but look to partner with others here to bring on some of our own PhD and research fellows from within our own kind of budget, which is relatively small, but also to partner with and facilitate others. And I'll give you an example of that in a moment. So we've been focusing mainly on structured data. In fact, it may be that for quite a long time we continue to focus on structured data because it's quite challenging enough in and of itself. And we've been working in this COVID-19 environment, and that's been, in many senses, a really great driver project for this work. So we set up around about March, April time, partly spurned on, partly catalyzed by the activities of a partnership between the British Heart Foundation and the NIHR Centres of Excellence with a cardiovascular theme incorporated. So that partnership called for projects to achieve or to gain national flagship status to respond to the COVID-19 situation from a cardiovascular perspective. So we used that route to bring together a UK-wide consortium of academics across universities with an interest in the connectivity between COVID-19 and cardiovascular disease, NHS bodies, and most importantly, data custodians across the UK and all 4 nations of the UK. And the ambition has been to link routinely collected data from across these whole populations to address 3 critical questions. Firstly, the impact of cardiovascular disease and its risk factors and medication. So this is pretty broad because risk factors for cardiovascular disease, of course, include those for many other conditions. So ethnic diversity, socioeconomic status, and more specific vascular risk factors as well. The impact of these on both susceptibility to and outcomes of COVID-19. The direct impact of COVID-19 on cardiovascular diseases, so the risk of acute stroke and acute heart disease in the context of COVID-19, and the longer term risk of these and venous thromboembolic disorders, for example. And then some work around the indirect impact as well of what some have framed as the unintended consequences of COVID-19 on cardiovascular diseases through changes in the configuration of healthcare services and public behaviours. Less people pitching up to hospital for when they have pain that might signify a heart attack, or hemiparesis that might signify a stroke, for example, or less availability for various reasons of the services that might improve the health of those and the outcomes of those individual patients. So 3 pretty big chunky questions, many of which can be addressed partially or to a large extent through the linkage of whole population-based routinely collected data that's already kind of exists but needs to be made. So probably the most important work we've done towards realising that vision has been with NHS Digital, although we've worked with the providers of these kind of data sets in Scotland and Wales as well, to a lesser extent Northern Ireland, because firstly it's less familiar to me, secondly it covers a much smaller proportion of the population, so 1.6 million of the 68 million in the UK are in Northern Ireland, and thirdly because their systems were less mature and less amenable to work with, at least in the last few months, although that's changing now. So our focus has been on England, Scotland and Wales, with a big focus on England because it needed fixing. And so we worked directly with NHS Digital by putting together this application with them as a key partner to work on the connections between cardiovascular disease and COVID-19, specified the kind of data assets that would be most useful in addressing those 3 questions, and in partnership with NHS Digital, put forward the application for those through the NHS Digital DARS and IGARD approvals process, but then crucially worked with NHS Digital to actually convert into a reality their idea of providing a trusted research environment to hold those data together for the entire population of England and make them available through remote access authenticated routes to researchers. They'd been thinking about doing this for some time. They just hadn't got around to doing it yet. And it would have been great if it had all been in place, but it wasn't. And so this was a really kind of compelling driver for getting it going, and other drivers have followed very rapidly once it became apparent that this was kind of starting to be established. You can see on this slide the major data sets that we've been working to pull together into that environment. We had hoped to have it fully operational by the 8th of June. That was the original ambition. Nothing wrong with ambition. That slipped, and so we did actually, by a few weeks, but we did actually have analysts accessing data within a new trusted research environment that had never been accessed within digital externally, without people being part of NHS Digital with contracts with NHS Digital, i.e. on the staff. That had never been possible before for external researchers. So we, by middle of July, had researchers from a number of universities actually accessing data within this environment. Now roll forward a few weeks, what's in there at the moment. So with some caveats, all of the HES and SUS data, so all the kind of hospital data for the whole of England, death registry data, so the deaths that come from interdigital from ONS, primary care data, so a lot of work in parallel to this has been going on to create a primary care data set that covers the whole of England within NHS Digital and has sufficient depth and breadth to be of value for addressing a wide range of questions. So the GP data for pandemic planning and research that many of you may know about, that's now available to apply for through NHS Digital application process, is incorporated in this environment. And there are some limitations of that data, but I think the key is that it's all in one format. It's all SNOMED CT encoded. It covers 58 million people, so it's nearly the whole of England. And there are lots and lots of codes in there that are well understood and have been used previously, and its coverage is broad. And we can come back to that in some detail if needed. And then we've also recently incorporated the community, I've called it prescribing data here, it's actually dispensing data, so it's community dispensing data. That's quite helpful as a complement to primary care data, which captures information on GP prescribing. The community dispensing data set captures information on what's dispensed from pharmacies. We haven't had a chance to really have a look at that yet. And then we've also been pulling in data through the NHS Digital route, which comes originally from Public Health England, so COVID-19 lab test data and the CHES data set. So those two and the four in the middle are the kind of key ones that are currently in the environment. There have been some issues with all of them, actually. And there are some details around the COVID-19 lab test data, which some of you will be familiar with. And there are some details around the CHES data set that do question exactly what they will be useful for. We are working very hard on pulling in cardiovascular specialist data into this environment, and also the intensive care National Audit and Research Centre data sets. Now the ICNOC data we haven't done a lot of work on as yet in terms of the politics and information governance, if I can call it that, because the CHES data set looked like it would give a lot of good basic information about patients with hospitalized COVID and their journey through HDU and ITU to give some good outcomes before mortality of what might be considered poor outcomes on any particular patient journey for large-scale epidemiological studies. Because there may be some limitations in the CHES data set, the interest in the ICNOC data has increased. That sits in NHS Digital. There are just some information governance steps to walk through in terms of incorporating them into this environment. So we'll be revisiting that. And on the cardiovascular data front, the NICL data are now sitting within NHS Digital. They're yet to be transferred into this environment. The stroke audit data are starting to flow into NHS data, into NHS Digital, and the National Vascular Registry are very keen to be involved. Their data are not yet flowing, but we're in active conversations about that as well. So this slide just shows how this might look, or does now pretty much look with respect to the whole country. So there are data sets of relevance now within an accessible trusted research environment in England, with some caveats. There are very similar data sets available in similar-ish environments in Scotland and Wales. They are not identical. It would be lovely if they were, but they aren't. So Scotland covers about 5 million, Wales about 3 million people, so that's a great addition. And Scotland and Wales both have different views of the data and areas where they add particular depth and richness, and currently far less expensive as trusted research environment operations than the digital one. But it's not yet possible to bring all of these data sets together in one location for working with them in one single environment. I strongly suspect it won't be in the foreseeable future, and that alternative methods will be required to perform analyses across environments. And there's much discussion about federated analysis methods and so on going on at the moment. Again, thinking about this from a sort of rather more simple point of view and art of the possible, then I think in terms of UK-wide analyses, for the foreseeable future, it's probably going to be about applying common analytic protocols within these different environments and externalizing summary results, and then conducting pooled analyses, various meta-analysis techniques would be appropriate for that kind of thing. So this just gives you a view. It's a little out of date because the timelines keep slipping, but this is the latest view of what's kind of available when in terms of this CVD COVID UK context. So you can see the data sets that are available roughly kind of lined up against the different countries within these trusted research environments. And you can also see that we've got a bit of a blank for Northern Ireland at the moment, and everything is not in place yet, because as many of you know who work with this in this kind of way, there are new obstacles popping up all the time, and all of these things take longer than one hopes, but you have to kind of just keep at it, really. So one nice piece of good news that came through earlier in September, because it's always nice to see real data outputs. It makes you believe that there's actually something there. So I'm not personally accessing this environment, but here's Jenny Cooper, who's an analyst in Bristol within the CVD COVID UK consortium, who is. And her investigations showed that there were indeed data in the GP data for planning, pandemic planning and research data set, pretty much as we expected. So just to summarize, 4 billion rows of data covering nearly 57 million patients. So that kind of looked quite promising to me, and I was very excited to see that, having spent much of the last 10 years chasing primary care data and trying to ensure good geographic coverage. Finally, this is a slight diversion, but I just want to share with you some of the work that we've either been doing within the centre or that I've been connected with loosely based on previous hats I've worn, or based on the current BHF Data Science Centre role, to make data and tools to interpret it and analyse it available in the public domain to help researchers, policymakers, the public and others make decisions. So we're not the only people doing this kind of work. There are many others who are developing fantastic risk modelling and other publicly available tools. But over the last few months, it's really been the first time that I've seriously engaged with this type of activity. And none of these is perfect, but it's been a very interesting journey to create some and then think about how one might develop them further and what would be the implications of doing that and to whom would they be useful. So I'm just going to quickly show you some of these. So this is one. This is not directly connected with the CVD COVID UK work that I showed you earlier, because it doesn't derive data from any of these national trusted research environments. It's actually based on some work to gather data directly from hospital trusts across the entirety of the UK, and it was one of the very early activities that the consortium suggested it would be worth doing, so we gave it a go. And it's really pretty out of date now, but it shows you the sort of thing that's possible. So we gathered aggregate data from, I think it was 9 or 10 hospitals from north to south and east to west of the UK. I don't think there's any from Northern Ireland or from Wales in this collection, but they do cover the north to south dimension of England and Scotland. And we've got some general hospital activity here and some cardiovascular specific activity here. And it just shows some of the patterns that many of you will now have seen and been aware of from a number of other sources in quite a nice updatable way, because there's a data submission portal here with the ability to upload simple data from a simple spreadsheet, which if we wanted to utilize that as a route could be a neat way of rapidly getting a picture of what's going on across the country. So you can see here how total hospital admissions with the solid red line showing what's going on in 2019-2020, and the dotted red line showing what went on the calendar year previously. You can see what's happened to total hospital admissions. So here's a Christmas dive, and it's identical for both the current year and the year previously. And here's the big dive in activity that occurred as a result of, or at the same time as, the major lockdown that we saw towards the end of March. And you can imagine what this might do afterwards and how it might be useful to track that sort of activity. If you want to see that in the context of the total COVID admissions, then those can be added in. You can actually see that obviously there are none of those for the previous year, so the dotted line is flat, but for the current year, the relevant year, the absolute numbers of those are actually pretty small in these hospitals compared with the big dive in cardiovascular admissions. That could mean a number of things. It could mean that it's really, really difficult to maintain this sort of activity given the requirements of this activity, which involves loads of PPE, lots of distancing, lots of special procedures in hospitals, cordoning of wards and units and all the rest of it. But the impact on business as usual is kind of pretty profound, really. Or it could imply, at least in some settings, that there was an over-adaptation by a combination of the public response and the way in which hospitals configured their services. And I wouldn't aim to make a judgment on that because I wasn't enough involved in any of those decisions or understanding exactly how it's worked. You can also look at, for example, accident and emergency visits as well. And you can see that they broadly follow a very similar pattern in the green here to the, sorry, they're in red and the hospital admissions have turned green. Apologies for that. You can see that basically these follow a very similar pattern. You can see some evidence of some recovery from May, and following some of these data on in time, that continued. That's one of these tools that we built that could be extended and made into something that could be shared with in a health service context. And some of these tools just feel to me a bit more usable and attractive than some of the systems that come out of government settings. We've also tried very much to have coverage that includes all 4 nations of the UK wherever possible, because it's very difficult to get across UK consistent view. One of the other tools that we've developed that looks at things from a cross UK perspective, I'm going to try and go back a little bit here to my slides again, is this one. I'm just going to show you one view of this. So this tool automatically pulls and updates data from the mortality feeds that come out of the 4 nations of the UK, England, Scotland, Wales and Northern Ireland, and helps to capture a picture of deaths and excess deaths and deaths by cause, major cause, in the different countries of the UK. There's some additional information within it, particularly for Scotland, of what some of the cause specific breakdowns are. But I think it's kind of most useful just as in the current circumstances, just as a visualization tool of the overall patterns of what's going on, at least at national level. And it's been very difficult to find through are various UK government outlets consistent ways of displaying information across the 4 nations of the UK. You can sometimes get it for England or England and Wales. It's difficult to get it for England, Wales, Scotland and Northern Ireland simultaneously. And finally, this is just a bit of a shameless plug really. The other foray into publicly available tools is this one. So in July, whilst I was on holiday, I kind of discovered that in my own head that mass population testing, which started to be talked about way before it sort of made its way into the popular press, started to be talked about in July, that there was potentially going to be a big problem with the generation of large numbers of false positives relative to true positives if there was not clear understanding of the role of prior risk or prevalence of infection and the impact of that combined with sensitivity and specificity of various different testing paradigms on false and negative positive outputs. And so we created an interactive tool, which is essentially an Excel spreadsheet, which you can download by clicking on this link, which generates for a whole range of different scenarios that you plug in the parameters for, out of a population of 100,000 with different testing paradigms and different immediate retesting paradigms, what you might see in terms of outputs of positives, negatives, false positives, false negatives, etc. It's starting to become a very useful tool in engaging with some of the policy discussions on this with government and some of the people involved in what you've heard called moonshot, which has sounded pretty crazy to many people. There's some quite thoughtful people working on that, and it's been really useful to have a shareable tool to engage with them with respect to policy. So that's not really core BHF business, that part, but I think it's just an interesting use of another sort of publicly available, potentially policy relevant tool. I've gone on far too long, and so I'm going to stop now.
That's great. Thanks, Kathy, for that. It's always nice to see these national efforts rather than group-based or university-based research initiatives. And it's really nicely represented in those graphical user interfaces, how you can actually visualize some of these and add value to all the data that you have that's available nationally. So while we wait for questions from others, one of the questions that I have is about this COVID-19 CVD project that you're doing. And you already have got a trusted research environment and the whole data linkage in place. So once after this becomes less of a priority because, the COVID-19 research is slowed down, can we actually use that framework and sort of amend that to include more strands to various projects that can be part of and that can use this data that you're already establishing?
Yeah, it's an excellent question, and that is absolutely my personal and I think the sort of broader consortiums and communities' ambitions around this. So from a kind of cardiovascular health data science point of view, the motivation of pulling in, for example, the cardiovascular specialist data sets into this environment, which has been set up in the name of a project that has COVID-19 written all over it, but explicitly actually part of the partnership with NHS Digital is to make it a long-term ambition, is that it will then enable many other much broader cardiovascular, epidemiological and other projects to proceed making use of those data within the trusted research environment. So probably the NHS Digital one is the kind of most exciting to people whose endeavours are likely to need very large scale because it offers 55 million people's plus data. Although I think the opportunity to kind of engage across environments is also very exciting to give a UK-wide picture. So there are obviously some, you won't be surprised to hear there are complexities kind of under the bonnet with all of this. So one can make those data sets look far more simple and pretty than they are in practice. And because we've pushed NHS Digital to do this work very quickly, They've pushed data sets into the environment without necessarily thinking through exactly what our needs have been, or without first developing a mutual understanding of what our needs were. And NHS Digital is quite a difficult organisation to work with in this regard. So the HES data that was initially ingested was not linkable to anything else. Actually, it turns out that there was never a proper solution for linking all the hospital HES data at population scale to everything else. So NHS Digital's really had to develop some new systems on the fly to support this, and they've done it knowing that it will support everything else that's their core business from a research and many other perspectives as well. There's just a lot of stuff that wasn't properly in place. So I was dumbfounded when I discovered that HES data was not routinely linkable at population scale. They'd been doing bespoke exercises for every single linkage prior to that, so for CPRD, for UK Biobank, and I hadn't realised that. And the same has been to some extent true of the death feeds that they get through from ONS. It's taken a bit of time to sort that out. That's coming in the next few days. Then, you know, with the COVID-19 lab testing data when it first came in, it was only the positive results. So we've had to go back and say, well, you know, it'd be useful to know who's been tested. So we need to know the negative results as well, please. And then you have to go back to Public Health England and all the rest of it. So, you know, some of you will have been engaged in these type of exercises. One of the reasons for doing this centrally is that it's so painful and kind of tedious and difficult that there's no point everyone doing it. So having some centralized resource do it on behalf of the community seems a really great idea. And then having it start off framed with perhaps one particular broad program of work, but with an explicit ambition for that to grow into much broader programs makes a lot of sense. So exactly how this service will spin out and how it will support broader projects outside of the cardiovascular domain, between the cardiovascular and other domains, and beyond COVID is not yet fully specified. I think there are great opportunities though to drive it forward by creating examples from what's currently available, which is quite chunky. Showing proof of concept, demonstrating to the public that this is a good thing to do, demonstrating to digital and other data custodians that this is a good thing to do, it's really valuable, and then kind of building momentum from there.
Yeah, and also having these sort of central resources is key to gaining public trust as well in what we actually do. Yeah, so great. So we've got a question from John. John, if you want to ask the question.
Hi, Kathy, thanks. Just wanted your take on tempo and likelihood of these linkages, which we've been talking about, which for various reasons that you've described are challenging to achieve. What do you think is going to happen next? And
my view on this almost changes on a day-to-day basis, actually. So it slightly depends on who you want to believe, but so the first thing to say is that I think quite a lot of this, you won't be surprised to hear, depends on kind of particular people sort of being in a position where they really buy in and choose to enable these linkages and data flows to take place. And a lot of that seems to be in a much better position now than it has been previously, but I think there's still some gaps to fill. So in terms of getting data into this particular kind of bubble within NHS Digital's new trusted research environment, if you like, then I think within the next couple of months, we will have at least some of the NICL data sets, and we've prioritized those, and the stroke data. And by the end of the year, I would hope that we will have all the NICL data sets and the National Vascular Registry data as well. If it's possible to speed that up, then we will endeavour to do everything we can to do that. And that's partly because I'm not actually convinced that these data sets are essential to answer many of these COVID-19 cardiovascular research questions. But I do think it's essential to use this momentum to drive forward the linkability and shareability of these data sets, and to test out in the context of the generic data sets what they are really useful for. And the sooner we start that, the more it can be transformed into part of the bigger picture and the longer term vision. So I think inside of this year would be my kind of best bet, given the sort of what we know of how things have progressed in the last few months. There are always some kind of drivers and risks and all the rest of it to all of that. So it's never a kind of done deal, and there are a few conversations yet to have with individuals to work out how willing they are to be particularly helpful in driving this forward, and that they're not too distracted by other issues that they consider more important. So I think it's large. It's as usual. It's not really any longer about information governance. It's not really any longer about technology or technical possibilities, and it's more about people infrastructure and communications. It's going pretty well, but not perfectly.
Great. I think we are on time with that. I do have a couple of questions, but it's always nice to meet you in person and talk about this. So we'll always follow up on these questions. And with that, also I want to mention, based on a few inquiries that I had about these HDI UK talks, we will try our best to share these talks. And also we are trying to arrange a YouTube channel where we host these talks, so people who have missed these seminars can actually catch up on that later. So with that, I would like to thank Cathy for a fantastic talk and taking a lead on such significant national efforts. So thank you very much for a nice seminar and for all the continued efforts that you are making, and all the contributions that you're making to this national research. Thank you very much, Cathy.
Thank you very much for having me. It's very nice to have an opportunity to talk to you. Thanks.
Great. Thank you.
Thanks, Cathy.
Thanks, John.